Hi, good afternoon or good morning, depending on where you are at. Welcome to our session today on survivors and thrivers of color, empowering the patient voice. My name is Crystal Payne, and I am the face-to-face coordinator in St. Louis. And today I will be your moderator. Just a little bit of logistical information. For more information on events that's happening throughout the conference, please check the schedule on youngsurvival.org. This workshop is being recorded today, and it will be available as well on that website on demand for 30 days after this conference. You must be registered to the summit to have access to those recordings. And after our speaker finishes her presentation today, which is going to be really exciting. We'll have a brief 10-minute question and answer session. So if you have questions for her, please put those questions in the chat and we will get to it afterwards. So it is my pleasure today to introduce to you our speaker, Dr. Keisha Bentley Edwards. Dr. Keisha is the Associate Director of Research for the Samuel Du Bois Cook Center on Social Equity, and she's an Associate Professor at Duke University School of Medicine. Dr. Bentley Edwards' research focuses on how racism, gender, and culture influence development throughout the lifespan, especially for African Americans. Her research emphasizes cultural strengths and eliminating structural barriers to support health development in students and families. She has published and lectured extensively on the use of racial socialization and racial cohesion strategies to facilitate positive outcomes in high school and college students. Dr. Bentley Edwards is dedicated to eliminating barriers to healthy birth and pregnancy outcomes, and she nurtures complex conversations around race and racism in ways that not only identify disparities, but prompt meaningful strategies for remedying these disparities. Her research has been supported by the Robert Wood Johnson Foundation and the National Institutes of Health. Dr. Bentley Edwards regularly shares her expertise on the role of structural racism and bias on health, education, and social outcomes with families, policymakers, practitioners, and the media, including New York Times, USA Today, The Washington Post, and CBS News. So please join us in giving a virtual applause as a welcome to Dr. Keisha Bentley Edwards.
Hello, thank you for that warm welcome. I'm really, really excited to speak with everyone today. I will do a quick share of my screen so that we can, get started. So there we are. All right, so and actually one more quick move over here. All right, so today this session is on empowering, and not just empowering the patient voice, but really being strategic about it. And so a big part of it is when I do work talking about Black women and health, a lot of what I say is listen to Black women, but it's not just listen to Black women, but listen to what we all tell you is the truth. Sorry, I realize that's on the screen. All right, so let's get started. So today our session will start off, we'll talk about context. I was trained as a developmental psychologist, so a lot of what I often think about the context of age, I think about the context of society and how it all comes together. And we'll talk a little bit about that. And then we'll get into what health systems need to do so that what they can do to be better. And then what you and your family members and your support systems can do in the meantime while the systems are working on themselves, what you can do in this moment. And then really, I want to talk about it and really have a really good conversation. And these pictures, I tend to like pictures of people really enjoying themselves and having, living a good life because we talk about heavy subjects. So I like to make sure that there's still joy in there. And so let's get in some of the groundwork. You hear context matters, you got to consider the context. When I was a kid in school, they talked about context clues when you were reading things. And this is really kind of getting at the same thing. So when I talk about context, you have to know about what happened before, and then to understand what's happening now, which is also going to inform what happens next. And when you are in that doctor's office, you are dealing with both what happened before you arrived in the doctor's office, and then the treatment is going to help you figure out what happens next. And so that's where that context matter, which is why you have to understand not only you have to share your own medical history, but also I want us to think about the actual field of medicine's history to understand why that context matters. And if you have questions, make sure that you put them in the chat and we will address them at the end. Sorry, I realized I had my notes here. So other things as far as context. So when we talk about the medical history, there are some major issues, and I like to bring up, especially when you start talking about women and people, specifically Black women and femmes. There's a history in this country of using Black women and Black bodies overall for medical experimentation. And this, what I typically point to during the time of enslavement is J. Marion Sims. So J. Marion Sims is known as being the father of modern gynecology and really the father of modern women's health broadly. He created the first women's hospital in New York. It was actually in the country, but it was in New York. But he became famous because he was experimenting on enslaved women in Alabama, in Montgomery, Alabama. And with these women, there are about 14 women who are confirmed to have been the subjects of his experiments, but it's rumored that there were many more because a lot of this work was cloaked in secrecy. But there were 3 women that he worked on extensively and repeatedly. One especially, Anarcha, who had at least 14 experiments done over 4 years with either no anesthesia or very little anesthesia. And what's important about this is that these experiments were done on Black women, but once the procedures were somewhat perfected, they no longer benefited from this. And so what you see is this history of women of color, and it's specifically Black women, being used to sacrifice for the common good, but not necessarily receiving the benefits of those efforts. And we see this also in the Puerto Rican pill trials, where the experiments around birth control pills were done on poor women in Puerto Rico. And then what we hear people talk about often are the Tuskegee experiment, where Black men also in Alabama, in rural Alabama, where my family is from. Now, I grew up in California, but my extended family, my grandfather was born in Macon, Alabama, was a Tuskegee syphilis study, which Black men, poor Black men in rural Macon, Alabama, were denied access to treatment for syphilis so that they can be observed over time. And all of these studies these days would not pass the Institutional Review Board's requirements. So that's something I want to be very clear, that part of why we talk about those studies is because it's lessons learned so that they don't happen again. But here's something that's really key, is that part of how these things were allowed to happen is that there are a lot of myths that still persist when it comes to how Black people and Black people's bodies. And so the big one is that, and may be relevant for some of the folks who are on this call or on this session, is that the idea that Black people do not experience pain in normal ways, have thicker skin, exaggerate pain. Another one that's big is race as biology. And I wanted to make sure I talk specifically about that. So when I talk about race, and sometimes you'll see people say race as a factor, but it's really not race, it's racism. It's when we talk about race as a social construct, what I'm talking about is that you can, although precision medicine is excellent, race medicine is not. The genetics that people point to are around race can be associated with regional differences, but it's not necessarily about race, especially not race in this country. We self-identify around race. And the other aspect is how Black do you have to be to get the outcomes? And really that can get a little murky. And we'll talk a bit about this more because I always get a lot of questions about this. And then also this idea of histrionic Black women. And as a psychologist, this word histrionic, it sounds sexist because it is. It's really talking about this idea that that women exaggerate or overly dramatic and attention seeking. And there's this stereotype of Black women as being histrionic. And I bring these things up not just because I want to bore you with history, but really because these myths persist today. This article in the New York Times was published in 2019. And what they found is that roughly 1/3 of medical students believe the myth that Black people have thicker skins than white people. And then why is this important? This has to do with surgery and surgical procedures, biopsies, things of that nature. So this is really important if people have this belief who are going to do procedures on you. And this was something that was documented in a peer-reviewed study and has been documented over and over again. And we're not just talking about these myths as far as Black people. This is from a nursing text that's a widely used nursing text from a book that was published in 2015. And I know it's a little bit hard, it may be a little hard to see, but in this image is a screenshot basically, or a picture of a textbook, and in the section on pain management. And it discusses how various ethnic groups respond to pain in very stereotyped ways. Black people, basically saying Black people will exaggerate their pain, as well as Jewish people, Native Americans and Asian people may hide their pain, so it's meant to provide cultural context, but in the ways that it overgeneralizes, it really sets people up to is actually used as a way to justify not providing appropriate care. And that's where it's important. So this textbook was written in 2015. This was the second edition of this textbook. And it wasn't taken off from the textbook until 2017. So this textbook as a whole is still being used today, but the publisher removed that page from new editions of the textbook and from the digital copies of the textbook. So these are really relevant issues if we're talking about people who were trained, 5 years ago, still being told by people that they trust or reading from reliable sources that you may feel pain differently. So this is where that context matters. And that's because these myths have consequences. We see these in the various places where we have standards of care. So if you want to see the biggest health disparities, you look at areas where there is known standards of care. We see this in heart disease, where young adults Black adults die at 2 to 3 times the rate of white adults of the same age of first-time heart attacks. We see this in infant mortality. And then as you see on the screen, Black children, adolescents, and young adults are more likely to die from treatment-responsive cancers than their white counterparts. So these things have consequences. And I bring all these things up not just to scare you, but really to say these things that you are feeling when you go in, you're like, I feel like they're not listening to me. I feel like I'm being ignored. They have roots in the system. So what this conversation is really about is systemic racism. And so this is where I'm identifying where it is in the system. And so let's think about what systems can do better. And this is where a big part of my conversation, and a lot of the work I do at the med school, I'm a co-lead on an area called Equity in Research, but we also work with equity in to really facilitate equity in practice and with practitioners as well. And a big part is listening, believing, and responding to your concerns. You know your body. You've been living in it for a long time. And so health systems need to actually listen to their patients and understand that their patients are part of the health, is a part of their treatment team. This one is important. Give equal access to best standards of care. So one of my colleagues here at Duke had just recently published a report, and this was about lung cancer specifically, where they looked at outcomes for immunotherapy treatment for lung cancer patients with Black and white patients. And this was looked at because there is a known, immunotherapy is known as the best standard of care. They looked at two things: disparities in who gets referred to those best standards of care, and looked at the outcomes, and then how it related to the overall disparities, mortality and morbidity. So, and morbidity is the actual sickness or severity of sickness that comes with a disease. And what they found is when you gave Black people the same care at the same timing as white people, that the disparities not only diminished, that the Black numbers were actually slightly better than for their white counterparts. And this was just published. And this is something that we have been talking about for years, but we're starting to get the evidence out there that if you give people of color the same types of care, the same quality. So when we talk about access to care, we're not just saying being in the same hospital and seeing the same doctors. We're talking about the same treatment, right? And so, so that is where is the biggest, and that's why I actually have that underlined as well. And then this other one, I know I just scared you with all these medical experimentation, but I will say that if you have, a cancer that is hard to treat or any other condition that has just not been responsive to treatment, you deserve access to promising cutting edge innovation. And so you should be asked to participate in clinical trials. It should be explained to you why this may work for you or why it may not. But there are so many clinical trials out there. I can tell you my own family has benefited from participating in clinical trials where we got more time with family members than we would have otherwise. So, I just want to say this so that it's an option. And then obviously to stop racism in their system. Oftentimes, health systems know who the bad actors are, and for various reasons, they are allowed to persist in those systems, and that's a big issue to be able to identify where racism exists within the system, as well as on the interpersonal level, and then to eliminate it. So these are the things that the health systems can do better. And so while they work on them, what can you do while they try to get their systems right? And that's where this whole conversation is really about self-advocating. And oftentimes we hear this phrase, you got to advocate, but not really what does that look like? How do you do it? And this can be very tricky for women of color, and especially Black women who, when we self-advocate is often seen as aggressive. Or that you are not just asking questions, but you are questioning, which has a different feeling behind it. So, but you have every right to. And so when you see that change in body behavior, you can say, I am self-advocating right now. You can actually say that I'm self-advocating, and don't be afraid to say that I'm self-advocating because I need to understand what is happening right now. What should I be doing? Ask questions, take notes, bring in questions. So as you have on your phone, have a note in your notes section. As you get questions, put those questions, and we go into the doctor's office, come in with that list. Doctors are very responsive to lists. I think it might be related to the med school process where you have to take notes and check off list. So this is make answering your questions a part of what they know to expect of when you come in. But this is the question if you are in treatment or you have to go back into treatment. Hopefully you don't, but for any type of diagnosis, this is a question I want you to ask. What is the best standard of care for my diagnosis and how do I get it? That is the question that you ask. Verbatim. And if they don't know the answer to it, then tell them, let's work on that. But what is the best standard of care? If you're seeing a specialist, they know what it is. And if they say, well, I didn't bring it up because I didn't think you could afford it. Like, no. I didn't ask you if I could afford it. I didn't ask you if my insurance covers it. I asked you what's the best so that we can do problem solving so I can get access to it. That is what self-advocacy looks like, finding out what it is and what we can do. The other thing is don't do it alone. Now, some of us have supportive family members that you can bring in. And if you have that, bring them in. If you don't have that type of support system, or oftentimes we are everyone else's support system, and we don't have that same type of balance in support. A lot of hospitals have nurse navigators, nonprofits get access to those folks. Say, I need someone, a health navigator, to help me, because especially when you are navigating cancer, you have so many different doctors and they don't always talk to each other. Sometimes they're not even in the same health system. To help you do all that, someone who can sit in the room, take notes when you feel like crap. The last thing you want to have to do is to ask questions when you just give me some medicine so I can leave. Have someone in there who can help you or who can be with you to take the notes, to ask, who can read your list of questions that you have on your phone. Use and ask for all available resources. If you're at a big health system that has a cancer center, they have resources. Ask for everything. Sometimes there's even maid services. Ask for all that. You deserve it. Don't feel like you're taking something away from someone else. There are folks who raise money just so you can have those resources. Use everything at least twice. The first time, you may not be sure if you like it. The second time, so you can know for sure if you want to use it or not. But at least know what they are, use it. You have choices. If you are unhappy with your physician, I don't care what their ranking is. I don't care, that they were on CNN last night. You can go to a different doctor. You can say you have a right to choose who is treating you and how they treat you. Listen to your body. If your body is saying something different than what that doctor is downplaying what you're saying, and especially this is the case for Latinas and for Black women, because we do have a higher rate of obesity. Go back. You have to ask Daddy. Sorry, So I had a small child break in. So if you, especially for Latinas and for Black women, we have a higher prevalence of obesity. So oftentimes we will discuss problems, our body, we know our body doesn't feel right. And the first thing that you'll hear, oh, well, you need to lose weight without any further tests. And it could be true that you may need to lose some weight, but you also know that this pain is not something I've ever had to deal with before, or my body is just not right. Listen to your body and keep talking to someone until you can get someone to listen. And then the last point I want to make is to report mistreatment. You all know that these hospitals, especially these health systems, as soon as you leave, before you even walk out the door, you get a survey. You may be tired of these surveys for every little person, especially if you see 5 different specialists in one day, you get an email. If somebody ain't treating you right, you go ahead and you respond to that. And if sometimes it's kind of tricky because sometimes the provider is treating you very well, but the gatekeepers may not, whether they're misgendering you, whether they are not respecting you, you can put in there and type in that the receptionist, made me feel like crap today. And I was already, if I was here, I wasn't even feeling good when I got here. And they didn't make me feel, you can put that in there and trust and believe they will respond. But also if you have excellent treatment, put that in there too. And so with that, I really want us to have a conversation. I'm excited to talk to you. I'm just excited to talk to you. So I'm going to stop sharing so that we can have this conversation.
Thank you so much, Dr. Keisha. I really enjoyed that presentation, and a lot of what you said personally resonated with me going through my process when I was diagnosed. I feel like having somebody with you to listen is always a good thing, because I realized that in my emotional state, I couldn't hear everything that was being said. So somebody else was there. So until somebody else put up some questions, I have a few. A lot of what you said seemed to be structural and institutional problems, right? Rather than problems on the patient side of things. So I was just wondering if there are any sort of training for like the new generation of doctors and nurses that deal with sociocultural sensitivities, I suppose.
Yes. No, I'm glad you asked that question. So this was something that you were starting to see a little bit especially the last 5 years. And where you find it the most are in med school training. And so I know at my school, we have an intensive year-long social determinants of health training for the first year of med school. It's a required where they talk about race, gender identity, sexual orientation, disability, poverty throughout the year in very intensive ways. And this is growing, and then it continues throughout their training process. And this is something that's obviously not just where I'm at, but you're starting to see, especially since 2020 with COVID, there's been a lot more conversations about the breakdowns in the system. We see, and I think what was a wake-up call, I know what was a wake-up call for a lot of health systems around these issues. We've known, especially when we talk about breast cancer, we know that Black women are later to be diagnosed and later to get treatment and more vulnerable to bad outcomes. That didn't really do it. It was when you started having successful Black folks having, really bad outcomes and being ignored. Like, wait a minute, if Beyonce is ignored when she's giving birth, Serena's ignored, what else is going on? And that gave a spotlight. But especially during COVID and people started talking about systemic racism, it may force a lot of medical systems to look within their own systems. So now you're seeing more required training that's happening in health systems. It's still too early to see how much that has helped, but we know that a lot of these these treatable conditions are have to do with what happens when you're actually in the examination room.
Yeah, thank you. That's really helpful. And I know I was really lucky to have a Black woman as my oncologist. So she really listened to what I said. But I remember being in that hospital in New York, because that's where I got treated, and sitting in the room before a mammogram. And then there's a lot of older women there who speak about older Black women, and other women of color who spoke about feeling something for years and being
Yes.
afraid to go into the healthcare system. And I know that your presentation touched a lot about these past experiments being done on people of color, especially Black people in the United States. And so how do we encourage our own communities to seek early treatment despite this distrust of the medical system?
Yeah, it's so much that goes into it, this distrust. And, wait, so I'm going to go and spend $50 to $55 copay for someone just to tell me that I just need to rest, or they're just going to go and tell me I need to lose weight. I don't need to spend that money to do it. Or what's even scarier sometimes, when you know that this is not going away and, you keep waiting for it to go away and it hasn't. And then you realize like this could be something big. So part of it is talking to your family and getting that support. You actually tell your provider, like, I was scared. I was afraid that I wasn't going to be believed, to actually to say that to your provider. It is helpful, but really, there is so much in this system that we can't control as an individual. The only thing we can really control is us. And so as I talk about systemic racism day in and day out, it doesn't mean that we don't have any agency in our lives. And so you pick the areas where you have agency. I can respond to what's happening to my body. And sometimes the relief of knowing that it really is nothing is great. But also if it is something that requires more or better treatment or focused treatment, that we can get that, because early diagnosis really, it saves lives. It saves lives. I can point to my first cousin. She had an early diagnosis, when she was 38, and it was treated. And she's still here with us. She celebrated her 50th birthday last year. And I'm so thankful for that. But I also have family members who had very late diagnoses, who through aggressive treatment and clinical trials, we had for more time. But I would love for them to still be with me. So that's what I tell people who feel something and know something and they avoid going to the doctors. It's like, what are the things that you want to see in the next 5 years or the 10 years? That's what you fight for. That has to be bigger than your fear.
Yeah, that's really great. Thank you. And so also, this is just a curiosity on my end. I don't know if anybody else felt this way, but I've been seeing a lot of people say that if you are trying to advocate for yourself and a doctor or a nurse denies you, say like a mammogram, you say you want it and they say, well, you're too young, that you should ask the doctor or nurse to put that down in your records. Is that something that
it doesn't, you can do that. You absolutely can. And for some, that's motivation, especially look, and that's not just for the doctors and for the next doctor who sees you, but it's also for you now, because now we have access, as of last year, you have access to your doctor's notes and your nurse's notes about you. And so if you want that in there for your own sake, to say, you know what, I thought I said something about this 3 years ago. I thought I mentioned that I felt something unusual. You should have that in. Say, I want it in my record. You can put that in there, even if they say patient complains of such and such and requested further testing. But it was deemed, but then they have to say why. They actually have to say why they said that it was unnecessary. Um, oh, congratulations, Ronice. Yes, I love to hear it. Um, so yeah,
Yeah,
that's a great question.
thank you. And I think maybe one final question, if anybody else doesn't have one. I was uh, I was curious as well. Oh, thank you for sharing that, Debbie,
Yes,
in the chat. That's really helpful. I was curious as well because I feel like sometimes we sit in the doctor's office and there's all these words going past us and we have no idea what it means. And you feel like the doctor is the one in charge. So you are like your position is automatically inferior.
absolutely.
So
It's the
either like
power dynamics.
exactly. There's a huge power dynamic there. And either you feel uncomfortable disagreeing, even though you don't quite have the knowledge, but you don't want to make a decision in that moment, right? You want to do your own some of your own research, and you may want to have a second opinion. But there's like all this pressure in that room to just automatically accept what is coming down to you. Like, how do we sort of break ourselves out of that or convince ourselves to have the confidence to slow it down and say, I need some time to think about this, or I would like some paperwork with what you are saying so that I could research it for myself.
No, that's exactly it. And so so one of the things I was thinking about were different, I wouldn't call them catchphrases, but phrases that will pique a provider's attention. So obviously, can you give me a printout of information? Like not just send me a link, but print it out right now so I can start looking at it. Can you tell me what are the best sites for me to, if I want to do my own research, where should I start from? Because because most doctors will be like, don't go on the internet because it is scary. You want to, you don't want to see a surgical procedure. You just want to know what the positives and negatives of the surgery is, so ask like, where would you recommend I look to do my own research? And then sometimes sometimes the support groups, those boards are great. And then other folks, I'm like, what are you telling me? Like, no, don't say that. This person's already terrified. Um, and then the other question, if something sounds off, you can ask this very specifically, Doc, can you provide the rationale for this plan of care? What is the rationale for this plan of care? And that is a question because that's doctor speak. And those are the questions that they ask each other. And they will stop. They will stop in their track. And so those are the questions that you ask. What is your rationale and why this treatment versus this other treatment? And so having those questions written down, having it phrased, and no one expects you to be a physician. Those words, look, I can't pronounce a lot of those words myself. Half of it's in Latin. We don't teach Latin in school. They didn't teach Latin when I was in school. They had to learn a whole new language, and sometimes they're used to using it. You can say, okay, break this down to me. You can pause and say, I need you to translate that, because sometimes they're uncomfortable, especially if the news, is kind of dire. And oftentimes specialists, especially successful specialists, have a hard time sharing bad news. I've been, as a family support, seeing doctors fumble through that. So this is also a reminder that doctors are human and they don't always get it right. So I do extend some grace, not all the grace, but I do extend some grace in their humanity too. But it's okay to say, you need to explain this to me one more time. And if you can't, can you bring in nurses? When you get a good nurse, they are your advocate also, and have them come in so they can help translate. Oh, Krista,
Oh, thank you. Perfect. Thank you so much, Dr. Keisha. And I hope that we could give her a virtual round of applause using the reaction button on the bottom
Thank
of the
you.
screen. Thank you so much. This was insightful, it was entertaining, and it was really helpful. And I hope we all got a little bit out of this. There are some links in the chat. One is a virtual support group for the Black community that Debbie shared. And another one is the link for the schedule of for the rest of our conference. So please click on that if you want to see what events are next. I think up next from 1:15 is a Never Have I Ever activity. So you could head over to that if you are interested. But thank you once again for participating, for attending. And thank you so much, Dr. Keisha, for answering all our questions.
Thank you. It really is a privilege to be here. Thank you for having me.